Well, good morning to everybody, and I really am happy to have the opportunity to talk with you today and give you some opening thoughts related to this issue of aging in place. We at the NIA are really focused on this. That's our whole reason for existence, to look at the aging process and how to facilitate the best quality of life and length of life for people in the United States and across the globe. So what I'll do in the 5 minutes or so that I'll be talking is to provide you an outline of the demographics of aging and functional problems and potential disabilities for the aging population. And in my last slide, I'll offer some areas for potential technology application. And I'm just really impressed with the group of people who are gathered here because you guys are at the forefront of thinking about these sorts of issues. And I think you'll be very helpful to my generation, the baby boomers, who every day there's another boomer turning 65. So we really need help in these areas. The primary data source that I'll be using is from 65 Plus in the United States for 2010, a Census Bureau publication that really just came out in the last couple of months. And I want to in advance thank Nina Silverberg, Melinda Kelly, and Ashley Triplett because they did the heavy lifting and pulling all of this together for these few moments. So for those of us in aging, this is a very familiar slide. The aging of the population has increased exponentially over the last century. At the beginning of the 20th century, very few people lived to 65 years of age and older, and now some 12%, 13% of the population is 65 and older, and that percentage is projected to increase further as we boomers age. Much of the increase in longevity at the beginning of the 20th century is as a result of better sanitation, the advent of antibiotics, vaccinations, better prenatal care and perinatal care. In the latter parts of the 20th century, some of the life extension is thought to be due to better measures to control blood pressure and diabetes and other sorts of things. And it'll be really fascinating to see what develops over the course of the next many years to further enhance a lifespan. With increase in lifespan, however, there's increased likelihood of one having functional limitations, and they're quite prevalent when you look currently at the older cohort in the United States. I will point out that people in disability realm, people in geriatrics often make a distinction between functional limitations and disability. People can have a functional limitation, but if they have means to adapt to that functional limitation, they're not truly disabled. But many times you'll see those two terms conflated. So what we see here is a representation of really the prevalence of functional limitations by age. There are some 20 to 25% of people 65 to 74 have some sort of functional limitation, whether it's in instrumental activities of daily living, being able to manage meals, medications, banking, that sort of thing, or basic activities of daily living, such as feeding, dressing, grooming. Going up to as much as 70% of people 85 to 94 years of age. When you look at it more specifically at people who are in institutional settings versus people who are not in institutional settings, and I'll point out that the vast majority of older individuals, even when you look at people who are 85 and older, are actually in the community rather than an institutionalized setting. But this gives you a sense of what some of these limitations are. 96% of people who are institutionalized, whether in a nursing home or assisted living facility, have some sort of disability, whereas 36.7% of those 65 and older in the community have such. And things that they have problems with are things like difficulty with dressing and bathing, a basic activity of daily living, difficulty with hearing. Boomers have a real problem with that, having listened to a lot of really loud rock music when we were younger. Difficulty with seeing, difficulty with doing errands alone, difficulty walking or climbing stairs, difficulty concentrating, remembering, making decisions, and all of these things can lead to a person truly being disabled because they're not able to compensate for these functional limitations. Living arrangements contribute to this as well. And what we see here is the living arrangements for individuals 65 and older with some 19% of men and some 39% of older women truly living alone. Women tend to live longer than men, so there are more men who are married or have some other sort of living arrangement than women who are married or have, they have some other sort of living arrangement many times because their spouses often precede them. And if they do go into an institutional setting, it gets to be very costly. Census data show that average cost of a private room in a nursing home is $229 per day, about $84,000 per year. And I'll remind you that Medicare does not cover the vast majority of that. Medicare will cover the first few months of a nursing home stay if there's a skilled need that was preceded by hospitalization, and then it's up to the individual to pay for that. Medicaid will step in and pay for that if one is sufficiently indigent. That means for the people who are middle income individuals who have not spent down their resources, they have to pay out of pocket for this. And assisted living is not usually covered by Medicare. It may be covered by Medicaid depending upon the state that one lives in. It's usually on average about $108 per day, $40,000 per year. And of course that's an average figure. Those figures can be higher depending upon what part of the country you're living in. So it's costly. And what has been reported, at least in the census report, is that there's about 3 to 4% of beds in nursing homes and assisted living facilities that are unoccupied currently, probably representative of the fact that it is costly, that there are barriers to taking advantage of it. And quite honestly, older individuals would prefer to be at home than to be in an institutionalized setting. So what are some of the challenges to people being able to remain in their own home and to age in place? One of them is that as we age, we're more likely to have accumulated various chronic conditions. As a practicing geriatrician prior to coming to NIH, it was not uncommon to see a patient who had high blood pressure, diabetes, heart failure, or chronic obstructive pulmonary disease or whatever. Osteoarthritis was a very common condition in the elderly. And that means that there is a need to manage those things. There are often multiple medications, and as a person becomes older and perhaps has frailty or perhaps has physical frailty or has cognitive impairment, it gets more difficult to manage those sorts of things. And thus, assistance is needed, whether it's technological assistance, institutional assistance, et cetera. And as was reported in an Institute of Medicine report in 2008, there's a shortage of trained professionals to help with these sorts of things, particularly frontline care individuals who would be doing that daily touching sort of care. There aren't enough of them. They're not adequately trained, and there's an opportunity to help to compensate for that potentially with the use of technology. So what are the opportunities? Here are some examples of a few. There are things that could be done for food assistance for some of the older individuals who are functionally impaired and potentially disabled. Currently, the Administration for Community Living provides Meals on Wheels and congregate meal sites, but there's the potential for technology to make it easier to cook at home if one has a disability. You could have talking microwaves, and I know many of you are working on these sorts of things. Motion detectors to turn off a stove when one is not near it for a long period of time. Devices that allow cabinets and kitchen counters to be lowered or lifted. Devices that could lift heavy appliances like a food processor. There are challenges with transportation, both as a geriatrician provider and now as the adult child of a cognitively impaired parent who lives a distance away. The paratransit and escort systems that exist are woefully inadequate. There aren't enough of them. They often keep you waiting for hours at a time for appointments, and there's an opportunity for improvements there. Urban designs, which create infrastructure to increase walkability for local residents, could be helpful for older adults throughout the spectrum, whether they're functionally have functional challenges or not, to keep them as healthy as possible. Mobile care clinics to provide healthcare services in place, and even better yet, telemonitoring to allow healthcare monitoring in the home rather than having to come out to a clinic. And again, I know many of you are working on that. Social networks to provide recreational, educational, and social programs to support the mental well-being of older adults. Again, being cognizant of the various cohorts, the current cohort of older adults may not be as adept at dealing with some of the technology that's there as, say, the baby boomers, my generation who's familiar with Facebook and Twitter and email, and who knows what will be there when we're in our 80s and beyond, and very likely in need of some degree of assistance. And family monitoring programs to support caregivers, particularly families these days often are in the situation where you have the adult children thousands of miles away from the parents and in need of an opportunity to monitor what's going on with their loved one, to make sure that the refrigerator has been opened, to make sure that they're moving around in their apartment and not perhaps having fallen, to make sure that they're taking their medications on a regular basis. And again, I know many of you are working on this and taking a leadership role, and I really commend the organizers for bringing you all together. Look forward to the outcomes of this meeting. Regret that I'm not going to be able to stay through this morning, but look forward to joining you again this afternoon and hearing the rest of the deliberations. Hope that this kind of sets a baseline for thoughts. Thank you.
Welcome all of you here today from the NIBIB, which I'll give you its full name and then its short name. So it's the National Institute of Biomedical Imaging and Bioengineering, and I think the operant word here today is the bioengineering. But the short version of who we are is the Institute of Cool Stuff. So that's kind of one of the tags that we like to think of. And in the context here of independent living, healthy independent living, I think one thing I can deliver, if you will, as a message is that the technology changes that have occurred over the last 10 years, over the last 30 years, are continuing and will continue for the foreseeable future. So if you think about, compare your iPhone to the mini computer, what's going to be here 10 years from now, and all of the thinking that you should be doing can very reasonably imagine dramatically improved technology that can at least fuel whatever it is you want to do. Unfortunately, it can't tell you what to do. It can just provide you the tools of doing it. But in terms of lower power requirements, so things that just work for months and can be unattended, more computation power, better connectivity to a broader system, and a much greater ability to work in the background. All of these things are going to be possible. And so in terms of thinking of the future, we shouldn't feel limited to what's available today. I think that what's coming will be radically different. The other tag that our institute is kind of been promoting is the idea of better, faster, cheaper. And I'm sure everybody has heard this before. You can get 2 out of 3. And what we're promoting as engineers is that what engineering is really about is delivering on all 3. That is, it's moving us into a new space where things really are better, faster, and cheaper. So that's sort of the 30,000-foot view of our institute. So how does this tie into, and how does this translate into a better quality of life for the aging population? And I wish I had a nice, clean answer as easy as that. It's a very, 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 very difficult question. And I think that the Institute of Medicine report on learning healthcare systems really got it right in sort of nailing what some of the issues are. And one of them is this issue of complexity. And it's the complexity of the medical problems. I mean, Marie just showed us the view of the 5 different, the frequency of people who had hypertension and diabetes and osteoarthritis, and speaking as one of the people that's in that population now. I mean, there are a tremendous number of us who have all 5 of them. It's very interesting to see. We had a fellow from CMS give us a talk a while ago talking about, okay, how unique are individual patients? And the answer turns out to be, and this is from CMS data, the answer turns out to be they're very quickly very unique. That is, okay, this person's got this, this, and this. So, which brings us to the concept of personalized medicine, but it also brings up the issue of complexity. And I think that one of the promises of technology is to give a way to potentially address some of the complexity of delivering care to this aging population in all of its manifestations. The other aspect is that they've raised is sort of the notion of using technology to improve the cost-benefit balance. And are we going to be able to control costs? And actually, Marie didn't talk about, I mean, we see the slide of the aging population going up. There's another slide which I thought maybe she would put in, which is the cost. And you know, if you've been looking, you've seen recently that the estimates are that that healthcare is starting to increase again, and that the estimation that it'll hit the 20% of the GDP is coming forward. How much is technology going to be able to impact that? And I hope that's a question that some of you can grapple with. I will say it's not obvious to me what the answer is. Clearly, okay, our institute also does imaging, and if you say, what impact has imaging had on healthcare in terms of our ability to do diagnoses, in terms of I'm trained as an internist, in terms of our ability to understand and have a better handle of what's going on inside a person who's not doing well. It's been absolutely fantastic. In terms of its impact on cost, it's been, well, that's a debate, but I can see a bunch of nodding heads, so I think I know which side of the debate many of you are on. And I think that same issue is going to come up here in this issue of the development of technology for home-based living. And that I'll just throw this out, and it's more a thought than anything else, and I will admit that it's somewhat of an unformed thought. But you know, the same way that you've got hospice care and for end-of-life patients, and there's basically a branch that occurs where in your healthcare path you go down one path or another path. And so the cost structure then changes depending on whether you're going down this path or another path. But they're really fundamentally different paths that you get on. And I'm just wondering myself, in terms of this cost equation, whether what we're talking about in a lot of what we're talking about in terms of home health care is really in some ways an alternative kind of pathway for health care, as opposed to the way I've thought of it up until this time, which is basically an add-on or a substitution, where these two things are kind of getting merged. And you know, you've got 2 days to talk about all kinds of things, but I just hope that you can maybe add that to your list. So you know, again, we are the Institute of Cool Stuff. I could give you all sorts of examples of neat things, but I actually didn't bring any slides here today. And my main mission is to say welcome. NIBIB has a real interest in these deliberations, and we're looking forward to see what happens here. So thank you.
So again, good morning. My name is Beth Minot. I'm a professor of interactive computing at Georgia Tech. But today, the hat that I'm wearing is I'm the vice chair of the Computing Community Consortium. So just as you've had welcome and introductions from our host here at NIH, I wanted to spend a second to tell you about the Computing Community Consortium and explain maybe a bit as to why we are here and part of this partnership, and then conclude with a few opening remarks, and then we'll go into our lightning introductions. So very quickly, the Computing Community Consortium is funded by the National Science Foundation in a cooperative agreement, and we're based in the Computing Research Associates, or CRA. Our mission is essentially to catalyze computing research agendas and to enable the pursuit of innovative, high-impact research. So our part of this partnership is bringing and engaging and informing and influencing the computer science of the computing community about the challenges and the problems and the opportunities for aging in place research. I love being part of an organization that, you know, part of the structure is that we're supposed to foment audacious thinking, and that's part of what we're asking for everyone in this room for the next 2 days. We also work in terms of outreach and connection to agencies. So we want to bring the community along, but then we also want to provide avenues and paths for this research to be possible within our national context. We spend a great deal of time working on communicating all of this out to the rest of the world. So check out our blog, not right now, but later. One of the things I think is important is that it's not just the people who are here now who are leaders within their field, but we want to continue to nurture the next generation of leaders. So a number of our activities, including a postdoc program in our Computing Innovation Fellows Project, as well as our Ellipse Summit, is about bringing the next generation of academic leaders to work in this wider context of research policy and engagement and shaping a national agenda. As an example, in the health domain, for example, we were involved in 2 workshops that both in 2009, 2012, that were on the moniker of Health IT. Part of what those workshops were about was helping shape and frame and inform and influence and cajole the folks that were eventually responsible for the creation of the Smart Health and Wellbeing Program and the Smart and Connected Health Program. There is no straight line, there is no clear path that says, we hold a workshop and, poof, a program comes out on the other end. Anyone who's familiar with this town knows it doesn't work that way. But the question is, how do we pull together, in my case, I'm often working with interdisciplinary research communities. How do we engage the community, catalyze their thinking, and bring them to a point where if such a program appeared, they would be ready to engage it and do terrific work. And that is in many ways kind of the lens for how I want to think about our work today. So I'm following 2 sets of terrific opening remarks, and I just want to add a little more context and also introduce some possible vocabulary for this multidisciplinary group to use during the next 2 days as we conduct our workshop, because we've got a lot of great work to do. And for all of you who have been involved in interdisciplinary research, you know that common language is often a challenge. And so I'm going to introduce some vocabulary terms, and feel free to argue with them, but at least start with them and we'll go from there. So I did not create the slides, and I knew I'm very thankful that Dr. Bernard did, the typical charts that talk about the tsunami of the aging population in our nation and others. But I wanted to maybe frame it at the level that from a healthcare perspective and where we are right now in the NIH, this is the crisis of our generation, right? Part of the reason we are facing this is because longevity is such a recent phenomena, right? And most of the folks who are ever lived to be 65 years of older today are currently alive today. So it's not that other generations failed to look at this. Other generations didn't have to think about it, but we do. And we're actually in a cusp of a time where, as I imagine many people in this room are also grappling with the crisis and care of their own parents. We're starting to see personally the limitations of the existing system, and are deeply committed for multiple reasons to do something much better. I know that when I started in this work, I clearly thought of it from an aging population, but one of the things that has become more clear, and again, Dr. Bernard made this remark as well, is that we also need to think of this as the increasing number of Americans with disabilities. That may be as a result of aging and disability that becomes the natural counterpart to aging, but it also has to do with our success in folks surviving, whether it's accidents or returning from war and engagement overseas. We have folks that are going to have very, very complicated needs as we embark on this. So why are we here? Okay, this is a scary slide, and I promise we'll get better, but what we want to think of is what is possible as the quote-unquote home as an extension and complement to our existing healthcare system. So that's one way to think about framing this question. Now, there's a couple ways that we want to play with that. Home means many things, and it means, for example, it can mean a natural occurring retirement communities. It can mean institutional care. It can mean assistive care settings. But it is a place where life occurs and where people frame their life in terms of their independence and quality of life. And as Wendy will quickly remind me, so she doesn't have to interrupt me, we're not just talking about healthcare. We're talking about health. And we're certainly not just talking about disease. And I think this is going to be important as we think about the frameworks or how we would evaluate the success of our work. We're talking about older people, we're talking about people with disabilities, we're pretty get close to everyone. Now, I'm not gonna expand the scope of this to technologies in the home for every person, but when you start also looking at the needs of caregivers, then you introduce another generation of individuals into this. So we're starting to look at a pretty complex and interesting demographic set. And again, when it comes down to brass tacks around what we're doing, is that we're looking at how do you enhance quality of life and independence of people, and using, quote, the home as the starting point for that. So there are many aging in place frameworks, and this is part of the language that I want us to use. So I stole most of this content from Wendy Rogers, so she doesn't have to introduce it in her panel presentation. This is Aging in Place 101. I assume everyone in this room is familiar with focusing on the concepts of activities of daily living, instrumental activities of daily living, which then goes to include engagement of areas of independence, such as preparing meals. Dr. Bernard mentioned that, paying bills, being able to be independent in one's own home, but then also the work that extends it to enhanced activities of daily living, which then we start to look at the ability to get out and play golf, involved in hobbies, continue with work and social communication as well. This is a framework that, to my understanding, has really come out of the assistive care community, and in many ways was preceded all of our computational techniques, but in terms of how to assess and understand someone's capabilities. And so we need to continue to refer back to and think of this as one of the fundamental frameworks of our field. Frailty is another framework that is, in some sense, more difficult to define, but as we start to look at computational techniques to assess the vulnerability of an aging person in their home environment, this is another useful framing for us as we start to look at the multitude of conditions that make someone more vulnerable to risk, to fall, to exposure, to some sort of catastrophic health event. And then finally, I think the hardest framework for us to grapple with, but it's something that we have to do, which is then how do we frame overall independence and quality of life? Because that is the priority of our aging stakeholders. It is not the priority of them just to manage disease. So if we start to look at remote monitoring technology, so pulling this from the work by numerous others that have looked at what types of remote monitoring technologies are in use now, and where are they contextualized with respect to their functions and their aspirations. So many of us, I don't know how many pedometers we have in the room. Everybody appreciated the steps they got this morning as we traversed Building 31. Many of us are engaged in technologies around wellness and prevention, so it is a useful set of technologies for us to consider. One of the nice things about that is that since it is considered a benefit to a larger demographic population, we can think of these as gateway technologies. We can think of these as technologies that people would begin to use kind of outside of the aging context and bring that into the challenges that we're going to be discussing over the next 2 days. Number of technologies that are being spun out daily, and I'm not even counting the Apple announcements, that look at chronic disease management. And again, we don't want to frame aging in place in terms of just disease management, but these are a host of technologies that one way or the other we're going to be grappling with. There's technologies that are specifically associated with acute care and post-acute care. Huge amount of interest now based on the readmission policy and reimbursement policies for technologies to follow a person home after discharge from an acute care setting. And then other technologies that have really gone under the aging in place moniker, and we'll look at those possibilities as well. So this is the worst chart. We'll get to the cartoons later. But this is, with some amount of apologies, borrowed and extended from the Orchitect architecture. You know, when we're looking in the home setting, part of what we are grappling with is what technologies are available in terms of just raw sensor data. So this is just literally the piece of technology that is measuring some piece of data, and that we want to combine or fuse that information into some sort of direct and useful assessment. So we may be combining information in terms of how someone is moving throughout their home, and whether we're detecting whether they're laying in their bed or not, and we would fuse that information together to try to get some sort of basic determination of sleep. Then from those quote-unquote direct assessments, we then want to fuse that information even further to look at larger scale characteristics, whether it's mobility as a whole, whether it is trying to have indicators of depression, whether we're trying to have indicators of overall cognitive ability and memory. So we have yet another level of inference. And part of where I extended this, particular architecture is I think part of our challenge for us going forward is then how do we pull those inferences together into these larger frameworks, right? How do they feed into ADLs or IADLs? How would we start to pull in information to have a overall estimation of frailty? How do we start to pull in all of this information for an overall estimation of quality of life? So again, as we talk through what we think is in the realm of possible, bring the rest of us along with you when you're thinking about, okay, it would require this level of fundamental technologies and this level of inferencing capabilities, and these are the missing parts, and that's part of our challenge for the field, is to understand maybe we don't have all of the information that we need to do a robust assessment of frailty. I don't think we do. All right, what are going to be those missing parts, and how would they fit into this type of architecture? And then, as a technologist, what I will say is our next stage is then we have to be parsimonious with these types of solutions, or understand how we're going to have to deal with very diverse types of settings and technology configurations. Much of what we're doing right now is the overbuilds, right? Let's put all of the sensors out there, let's put all the capabilities out there, because we need to understand what is possible. But then the next stage of this process is to say, okay, now that we understand all things that are possible, what are the, a good question for us is then what are the smallest number of sensors? What are the smallest number of characteristics? Because each one of these implies a cost. Each one of these adds more complexity within the system. And so from a machine learning perspective, you would frame that as, okay, I have a number of different markers, but what are the primary ones that I need to focus on? We're not all machine learning experts, but it's the same question, right? Within the realm of all of these possibilities, what is going to be the most parsimonious, most robust set that is practical for the situations in which we're designing? So Dr. Bernard talked on a number of these issues. I'm going to go through these in a way that it's not just about the demographic of our populations, but many of the realities that this group must deal with. And in some senses, I think one of the most interesting research workshops I've ever been part of, because we're asking you to do two things at the same time. We're asking for your most audacious thinking in terms of what needs to be accomplished by our community, but we're also asking for that audacious thinking to be deeply rooted in the realities of what an aging in place research program would need to solve, what types of solutions need to be out there. And when I mean realities, I don't mean realities as we need to accomplish it tomorrow, but I mean realities when I talk about the complexity that is paramount with the situation. So Dr. Bernard also mentioned women and aging, so I will touch on this briefly, but women are more likely to be alone. They are more likely to be fighting with poverty, at least twice as the male population. They're going to live longer with chronic disease at also 2.5 times the rate of men. One of the things, and I think this is referred to as the Golden Girls phenomena, is women that are starting to co-locate together and figuring out new ways of having someone else within the home as a informal caretaker and just another set of eyes and ears. So when we start looking at the demographics and start looking at the challenges, we're going to be working with women who are living longer, they're going to be more ill, and they're going to be more impoverished. And that's part of the realities that we have to work with. We've already mentioned this as well, but there's nothing static about aging. And I think this is a challenge for my computer science colleagues, which is that we're used to designing to kind of a static need. And we're happy if someone uses something for 2 years before they discard it and adopt something else. We don't have that kind of luxury in what we're working with here. Successful aging used to be defined as the absence of chronic conditions, but 77% or more of seniors suffer from one or more chronic diseases, and that number rises to 85% for those over 80. We're dealing with very complex and interesting individuals. And even if you just think about how much your health needs have changed over 30 years, there's no reason for us to anticipate that that rate of change and that diversity of needs wouldn't also apply within the senior demographic. There's also system administrators who are few and far between. I used to work in broadband technologies, and so you referred to the cost of a truck roll, right? The cost of having to take the truck to the house to update or change or fix the box. I remember back in the day, and I think folks have gotten better about this with wireless networks, but everyone thought that home printing was going to be the solution to getting people to adopt home networks. And instead, people just eventually waited for printers to become cheap enough, and then they bought two. Right? So instead of having to figure out how to network the printer around the house, it's like, okay, fine, here's my machine and my printer and your machine and your printer, and we don't have to worry about that network. Now, we've gotten past that with broadband technologies and everyone's interpretation of what they think the cloud is. But nevertheless, we have to be realistic about what the technological landscape of the home looks like. Cell phones are supposed to be replaced every 2 years or faster if Apple and Samsung get their way. And many of the technologies that we work with daily run on those types of cycles, but that's not the cycle that can be used in the home. I remember as a UBComp person, for a while we were all excited about smart refrigerators, that we were going to use the refrigerator as the base for calendaring applications and food monitoring and all these kinds of things, until someone reminded us, you're lucky if someone replaces the refrigerator every decade. All right, so the refrigerator cannot be the platform for next generation computing technologies. So we need to have realistic models of technology adoption and sustainability, and we need to understand that we exist somewhere between the consumer cycle time of 2 years or less, the medical device cycle time, which seems to be about every 3 to 7 years, and it's based on reimbursement policy, and it's based on whether it's home or personal technology or technology within an acute care setting, or the home cycle time, which is at least every decade for every major appliance. So we're existing within that landscape, but think about the truck rolls. Think about the cost associated with bringing a next generation technology into the home. And we'll talk at the break about what it means for internet security technology as well. Whatever we do, we're going to have very, very messy data. Because we're going to be looking at a landscape where some of the technology in the home may be post-acute care technology. Some of the technology in the home is what the kids went and bought at Home Depot, and they've installed in the home for caregiver awareness and monitoring. Some of it may be an extension of the security systems in the home. And then Lord knows, some of it will be based directly on chronic disease management. So we're going to have very diverse environments. We're going to have less control. We're going to have diverse data both in scope and origin. No one patient, no one person is going to have the same data associated with them, and that data is going to be serving many stakeholders, right? So this is the reality. This is the complexity that we're dealing with. However, not to offend my NIH colleagues, but we need to remember that people are messy too, all right? People are taking, in the 60 to 69 years, so they're taking an average of 14 prescriptions per year. Okay, that number goes up to 18 once you get into your 80s. And there's a whole set of statistics just related to adverse drug reactions, responsible for 28% of hospitalizations, and just even the number of hip fractures that are associated with medication problems. And part of what I want to point out to you is for every single clinical trial that is out there that is informing how a person is being cared for with chronic disease, those clinical trials do not deal with the complexity of people taking 14 to 18 prescription medications a year. Right? There is no perfect match between this patient who presents themselves and the complexity of just their medications, not to mention their home environment and all these other environments. So we have an opportunity to bring the reality of those complexities into the healthcare domain. And when I mean opportunity, I'm saying we have a lot of hard work to do. But that is the realistic assessment of the complexity of this population. So I'm cheating a little here because I know Sarah's panel is going to cover all of this. But we have to keep reminding ourselves that healthcare and health are not the same thing. When I started working in aging in place technologies, and this is because Wendy Rogers was teaching me how to do this back at the turn of the century, I was a very earnest young researcher, and I was working on caregiver technologies, caregiver awareness. And so I would go interview older adults with my very earnest concerns about how their sons and daughters wanted to make sure they were okay, and I wanted to develop monitoring systems to help that. And one of the very first questions we got was like, okay, well, that monitoring system sounds okay, but will my kids be able to tell when my boyfriend comes over? Like, okay, that really wasn't on my radar as kind of the top level priorities of my frail aging adults that I was going to help take care of. These folks are rightly working from the same priorities that all of us have, right? Living a full and wonderful life, going to the beach with our 95 SPF sunblock perhaps, and our bifocal sunglasses. And I think it is a challenge to our community to understand that we exist at this cusp of medical intervention and making life worthwhile. And we live at that very challenging intersection. So that's part of the reason we're starting with Sarah's panel, is that we are firmly grounded in the complexities of both what individuals are grappling with and their priorities. But if nothing else, I just really love that cartoon. Remind me again, who's chasing who? So the last challenge that I want to mention, I think it's the last, and then we'll move into some possible paths towards solutions, is that, again, as a previous speaker mentioned, aging in place exists within multiple larger economic contexts. And part of our challenge is to not only come up with scientific valid approaches within aging in place, but then how do they also provide economic value with whatever context they exist in? And there are multiple contexts. So Tiger Place team is here, so hopefully everybody did their pre-read homework. There will be a quiz. As one example who has started to push on the forefront of that, we're going to hear about Orchitect, we're going to hear about Eldertree, we're going to hear about others. But I will humbly say to you that we're just really in the first 5 minutes of that for us to understand how do we have this systems approach that provides hard scientific evidence of its value and works within an economic context that can be successful in our nation. And there's many contexts that we can continue to look at. So this is to wake you up and to make you wonder why in the world Neil deGrasse Tyson is now pictured here. So my kids love Neil deGrasse Tyson, and you have to be very excited when your adolescents want to watch Cosmos. But I was looking for the metaphor to get everyone's attention to say, what do we need to do scientifically? All right. So Neil deGrasse Tyson will tell us about these amazing observations that astrophysicists have had. And I love the one where we thought it was 1 star, but now that we have better observations, we understand that it's 2 stars, and they're circling each other in this beautiful complementary orbit. And we know that they exist, and folks have done great scientific work to put that evidence out there. And this is a terrific community, and we have done great scientific work in aging in place, and we have lots of evidence that are out there. But we have these circling stars, and they exist, but in some sense we haven't done the work to then integrate it into our larger theories of astrophysics. It's like we don't know how it connects with the rest of the system. We know, we believe it's true, and reputable scientists will believe it's true as well, but then the question is, how does that integrate with the rest of our science, with the rest of our understanding of how the universe works? And so what I want to humbly say to a bunch of extremely talented and reputable research in this space is our challenge in this is how do we create the science that helps us demonstrate the validity of the aging in place approaches that we're doing now, right? And that is what we are being asked to do in multiple contexts. And what I mean by that is that there are a number of different possible paths ahead where we have connections, we have handoffs that we can make. But for example, if we're going to say that we're doing advanced data analytics around frailty, we have to do the hard work of science to say what is our robust definition of frailty and how do we measure that and how do we share that as a community? All of the things that come around the scientific community as well. If we're going to say that aging in place is going to work around care coordination, okay, what is our robust definition of care coordination? How do we actually establish that as an empirical framework that is repeated from Tiger Place to Orchitect to Eldertree to the 20 that are going to be announced today that are existing in the commercial space, so that we can build up the evidence base that says if you apply these interventions and your emphasis is on care coordination, here is the hypothesis-based research that proves the validity of these approaches, and by the way, then also exist within an economic context which is feasible. So we don't have to all choose the same scientific framing, but the challenge exists for all of us. And some of us are going to work purely on the data side. Some of us are going to work more, I think, on the care coordination and the care delivery side. Some of us are more and more interested in healthcare as a whole as an engineered control system and how to build into that. And some of us may just focus on consumer adoption, right? And there's a whole set of other possible proofs and framing that are just about messaging straight to caregivers and to families. But right now, what I feel is we have we have our stars that are rotating, right? We have a sense as to the possibilities within the universe, and we have lots of data points that are out there, and we have collectively as a community excitement about that, but we need to do the work to integrate it within the rest of the scientific community, within the rest of the healthcare community, so that we can take this next very difficult step, which is to take this from proof of concept excitement to something that can be deeply and reliably accepted and used by our nation. So I think as we go through the panels for the next 2 days, these are the types of paths and others that we're going to explore. And my request to you as we dive deeper into these discussions is that you continue to refer to and add others, as I've missed some, kind of the frameworks that we are building toward, that we're going to talk about the science that's going to be necessary for us to have reliable, provable solutions within this space, and that we understand and think deeply and communicate well about kind of the diverse stakeholders and how we are trying to meet those needs. So our structure for doing this is we have hoped to recruit kind of the best, the brightest, the people who would say yes, a number of folks who are willing to instigate our discussions. This is not a traditional conference, and it's certainly not a classroom. The way that this is structured is our panelists we have begged, pleaded, requested, demanded everything to say that we want the panel presentations to be concise and that we have 50% of the time in each session available for discussion. We have many note takers who will be furiously capturing everything that you're saying, but we're asking you to take these conversations deeper. There are no novices in this room, right? All of you are already experts in this field, and this is our attempt, very earnest attempt, at tapping into your collective insights that need to happen as a community in terms of where we need to move forward. So we're going to, I think, start this off correctly with looking at the realities of designing for older adults. We're going to then pair that in some sense with the horizon of technological feasibilities, especially in sensing, actuation, and system integration. The last panel of the day is going to attempt to pull this together by looking at different types of health transition trajectories. So they're going to start to pull together the needs and the data and the technology through a number of different scenarios. We will discuss, if any, what homework we're going to have this evening, but we'll send you home, including a very nice dinner-laden reception for continued discussion amongst our community. And tomorrow we're going to come back and make it even more difficult. Tomorrow we're going to come back and look at more holistic systems approaches, where a system may be the extension of a healthcare system, the extension may be how we take care of veterans, the extension may be how an entire assistive care community could operate. And then we're going to have, and we left them for last, but then we're going to have all of the folks who are then dealing with the edge of policy and reimbursement and FDA and all of that rest of the complexity that our world exists in. Hopefully these folks are here and with us throughout these 2 days, and we'll be remarking on not just the feasibility, but the excitement of the visions that are coming from this group. And then we've asked the session organizers to come up with some very brilliant and concise summary remarks as we finish at lunch. For those of you who are curious, there will be a post-workshop action. We're not just here just to enjoy each other's company, although it's a wonderful opportunity to get to work with all of you. Very quickly, the team will be putting together an executive summary of this. And one way or the other, what we have been asked to do is provide a research roadmap that lists the challenges and the priorities that our collective field must address in the next 5, 10, and 15 years. So last request in your vocabulary is you start thinking about near term, midterm, and far term in terms of what we want to accomplish and what we think is a audacious but reasonable challenge for our field. We will work towards wider dissemination of this through a journal publication, but the overall perspective of this is to inform and influence. There are many stakeholders that are not even in this room, but are very curious about what this group is going to come up with. They are asking us to meet, they have funded us to meet, to come together and to be able to give them the scope of what the Aging in Place research agenda should look like. So we have folks that are waiting, very, very interested in terms of what we can do. So it'll be a terrific set of conversations, but it won't be just that.